virtual experience of a CSO. It is a period of change, and even if the future will be different, we want to be closer to our client. For this, today, you'll meet our product specialist, the virtual booth, and later the key opinion leader. Enjoy the day and see you soon.
Thank you very much, Veronica. And on behalf of CSO, I'm very happy to open this meeting, this webinar, as we say. We have three tremendous panelists, plus myself. And I don't want to waste your time. I'm just giving the microphone to Erik Mertens from Belgium. He's a tremendous surgeon and has a lot of experience as regards CSO technology as well. He is one of the leaders in the world as the implantation of the ICL. So he's going to give us some insights about the use of anterior segment OCT and ICLs. Erik?
Thank you, Francesco. Thank you very much for your very kind introduction, as always. So I'm going to share my screen now. Okay. So first of all, good morning, good afternoon, good evening, friends and colleagues all over the world. This is Erik Mertens from Antwerp, Belgium. And I would like to talk to you about ICL sizing by anterior segment OCT. And I'm measuring the scleral spur to scleral spur, which is a little bit different than most of you probably are doing right now. I would like to thank CSO for the invitation. I'm also, that's my financial disclosure, I'm also a consultant to CSO. And we're going to talk about the anterior segment OCT, the MS39. This anterior segment OCT has a lot of applications, as you can see here, but the ones which are relevant to this presentation are the two in red, the anterior chamber measurements and the dry eye anterior film analysis. Now, when we try to do these parameters, we need to do it fast. We love to do it fast. It needs to have a high repeatability, non-invasive, so the patient's comfort is very important, and also it's patient friendly. Now, how can we make ICL sizing more predictable, more easy and repeatable? And this is what we do preoperative when we evaluate eyes preoperative for ICL implantation. First of all, when we measure the eye, I look at the acquisition quality. As you can see here at the right top, coverage 100%, centration and keratoscopy coverage also very high, almost 90%. It's all in green, so we know this is a good measurement. When you don't have this, then please try again, because you can end up with false measurements and also false outcomes. The second thing we do is we look at the break-up time, the non-invasive break-up time, which is also a very nice feature on this instrument. And as you can see here, the break-up time, you can see it on the keratoscopy, and it is visualized here. Because when you do ICL surgery, one of the main reasons for over or under corrections is an unstable tear film. So tear film insufficiency is to be treated before surgery and is even before you do a pre-op refraction. So when we see this, we're going to treat tear film quality first and let the patient return in 3 to 4 weeks until we get a good tear film, and then we can use that pre-op refraction to order the ICL. Now, another map I'm looking for is the choice of the 4 different maps. This is this one. And you see here, lower left and lower right, the anterior and posterior elevation of the cornea, the pachymetry, and here the tangential anterior. This is very important, but the most important is this button over here. I will highlight it there. And when you click, excuse me, this is a little too fast. Let's go back one slide. So this is the epithelial thickness map. Another source of error is when the epithelium doesn't have a nice, well, actually it has to be within a few microns all over the cornea. As you can see here, we have 54, 58, 57. So this is a very nice distribution of the epithelium over the cornea. When it's not evenly distributed, And you need to take care of that as well. You have to look for the cause and treat it, and not treat the eye's refraction, not putting the ICL, because again, you will end up with a bad result. Except for the central corneal thickness, the anterior segment OCT MS39 also gives you the anterior chamber depth, as you can see here, and it gives you the anterior chamber depth from the endothelium to the anterior capsule of the crystalline lens, and the real corneal thickness, and it gives the two numbers, and it adds it to the total thickness of the cornea. On top of that, the angle to angle and the anterior chamber width, which is the distance between scleral spurs. And this is the map you're looking for. First of all, look at this, that you're measuring from nasal to temporal, meaning in the horizontal axis, because this is the axis you're going to implant the ICL. And actually, the system detects the scleral spur automatically. And when it does not detect it automatically, it will tell you, and you can decide whether to retake the examination or look for the scleral spur yourself. But most of the time, in most cases, it detects it automatically. And then another feature which is very important in the calculation of the ICL diameter is the crystalline lens rise. And the definition is, and I quote, the distance between the straight line connecting the both angle recessions, the straight line in nature. And the next slide will explain to you that on the image it's not a straight line, and the anterior surface of the crystalline lens on the linear bisector connecting both angle recesses. So this is how it looks like on the instrument. I told you it is a straight line, but actually on the image it's not a straight line. Why is it not a straight line? Because the refractive indices of cornea and aqueous are different. So when you are tempted to draw a line in between the scleral spur to scleral spur, you will end up with a false measurement. Again, the system does this automatically. Do not try to do it yourself, because the system knows exactly where to draw the line, and you cannot do it based on the image of the patient, because the diameter of the cornea can change, the anterior chamber depth can change. So the measurement on the system is the right one. And you can find it here under summary indices, anterior chamber. It will tell you scleral spur to scleral spur, 11.84 millimeters, and the lens rise, minus 0.16 millimeters. Also have plus sign or minus sign. You have to take this into account when you put it into the formula to calculate your ICL diameter. Up till now, this is the formula we're using. It's the formula published by Nakamura in the American Journal of Ophthalmology in 2018. And this is the formula. I will not dictate it because it's in front of you. And when we put in the numbers, as 11.84 and minus 0.16, and we calculate it, we get a final number of 12.62. So in this case, I implanted a 12.6 millimeter ICL diameter. Currently, we're working on optimizing this formula for the MS39, because this formula was not calculated for this anterior segment OCT, but we hope to come soon with a new formula specifically dedicated to the MS39. So this is what we implanted. Postoperatively, this anterior segment OCT is very useful in measuring the postoperative vault. And this is what we got in 36 consecutive eyes, and 1 month, 3 months, 6 months, 12 months postoperatively. And as you can see, all of the eyes were within 100 and below 1000 microns 1 year after surgery. So the predictability involved has increased a lot due in reference to other formulas. So you can evaluate the positioning of the ICL postoperatively, as you can see here. Here, measurement of the high vault. You can see this is a hyperopic ICL because it's thicker in the center. You can evaluate the angle here, and when you're in doubt, you can take out the ICL, put in a new ICL, a lower diameter, to get the angle wider than when you're not pleased with this one. This is a very nice picture, and there was something wrong with the eye post-implantation, and this was published in the book by CSO actually. And here the iris is forward displaced, as you can see here. And this is a magnification. As you can see, the ICL was inserted upside down. So also in doubt with this anterior segment OCT, you can actually see what happens. And the problem was quickly solved. You can take out the ICL, reverse it, and put it in the right direction. Another nice feature on this anterior segment OCT is a dynamic evaluation. And look here carefully. When the pupil constricts, you get a smaller vault. So bear in mind, a vault is not a static number. Vault after ICL implantation is dynamic. And when the pupil constricts, you get a different vault. The thing is, with the newest version, the Aquaport, from the ICL V4C onwards, it's not a problem anymore to have vaults less than 100 microns. I personally have 23 eyes with vaults less than 100 microns with a follow-up of 5 years with no lens opacities of anterior lens changes whatsoever. So lower vaults with the newer versions of the ICL is not a problem anymore. And you can evaluate even with pupil constriction with this instrument how the vault changes towards the crystalline lens with constriction of the pupil. So in conclusion, this OCT method is more practical for ICL sizing than UBM because you don't need the water and so on to do the measurement. The equation for ICL sizing we used with Nakamura is even more appropriate to select the size and more accurate. We had an accuracy of the vault prediction, 72% was within 0.18 millimeters and 95% was within 0.36 millimeters. And actually, this is a non-invasive tool, pre-operatively and also post-operatively, to see whether everything is going well. It gives you a complete anterior segment evaluation. It can very nicely predict the vault size and the measurement, which diameter, of course, to implant. And it can evaluate post-surgery the dynamic relationship between the ICL, the iris, and the crystalline lens. And thank you very much for your kind attention.
Thank you, Erik, for this excellent lecture. Very useful. I'm asking if there are questions to the audience. In the meanwhile, I'm going to ask you my first question. So this technology is amazing because it allows you or us to do all of that. How did you move from other technologies like UBM or high frequency ultrasound to OCT? So what are your thoughts regarding OCT and other technologies?
That's a very good question, Francesco. You know, in the beginning, we used white to white, but all the instruments give different numbers, white to white. Although 90% of the ICL sizing was okay with it, but yeah, still missed 8 to 10% with the white to white. Then I changed to UBM. But the problem with UBM is you can look behind the iris, but it's very user dependent. You know, one optometrist to the other isn't as skillful. It looks at or the patient is not so cooperative. And on top of that, you have to put in the shell on the eye and fill it with water, which is not so convenient for the patient. So it's very user dependent. And also where to put, where exactly is the sulcus, where will the ICL sit on the zonules or further away. It's very difficult to predict. And therefore, I moved to the anterior segment OCT because, yeah, you don't have to touch the eye. It's very repeatable. You can have 3-4 optometrists and you will get the same measurements over and over again. And yeah, the scleral spur is very easily, in most cases, it's very easily detectable by the instrument. So there is no doubt where the scleral spur is. So it makes it very reliable and repeatable measurement.
All right. Regarding this, there is a question from the audience. Is white to white with the MS39 closer to that from the orb scan?
Well, actually, I don't know. I don't know. I have to compare because I don't use the white to white anymore. I lost my interest in white to white, so to say. I can't answer this question because I'm not taking that into account anymore.
And as regards the Nakamura formula, do you think that it works similarly in Caucasian and Asian eyes?
Well,
any differences?
Well, of course, my population is only a few Asians we do surgery on. In those cases, I did not change the formula. Nakamura is, of course, in Japan. I just copy pasted it to here, and I get good results. So I don't think there will be an enormous change. You don't have to change it. I didn't change it, so there is no need to change the formula for Caucasian or Asian eyes.
I'm just reading questions as they come. Do you include the cylinder in calculating non-toric ICL power, or ignore it to use a best sphere?
But this has nothing to do with sizing then, no?
No, this is not sizing.
No. So, well, I always would try to correct the cylinder, and from 0.75 diopters onwards, I always use a toric ICL. Because in those young eyes, when you try to correct the cylinder with limbal relaxing incisions or counter incisions, those corneas are very elastic, and there is a wound response, and you cannot predict it as well as to put in the toric ICL. So from 0.75 diopters onwards, I always use a toric ICL.
So if you don't mind, I'm keeping on asking questions. Is NK formula okay for other devices like Anterior or other OCT devices? Are you familiar with the NK formula?
No, I'm not familiar with that formula, and I do not have experience with other anterior segment OCT, so I cannot compare.
Me too. I'm not aware what this NK formula is. Maybe Pierre, if you want to write something more, we can discuss it a little bit further. Just let us know exactly what you mean for the NK formula. Another question is the question reads: is it comparable with anterior segment OCT with CASIA? Because it measures a perfect A to A distance.
Well, the same answer. I don't have any experience with other OCTs. I only use this one, MS39. And yeah, comparison, I cannot comment on that.
All right. And this is another question that is interesting. If we don't have an anterior segment OCT, what would you do now?
What I do now, what I would do? Well, I would still do UBM then, because UBM was pretty good. I would also I would go back to white to whites and UBM and compare them. And when they give the same result, the same ICL size, I would go for that. So I would do both methods instead of the anterior segment OCT.
And another question reads: how much is the error in sizing by the anterior segment OCT? So do you have any like standard deviation to give or so?
Well, the predictability is very good. As you saw, it's 0.36 millimeters. We were within 0.36 millimeters in 95% of cases. So the measurements are pretty reliable, as to say, with the anterior segment OCT.
Believe it or not, you still have 16 questions to answer. So take your time. One question reads: how to determine where is the scleral spur if the machine could not identify it automatically?
Yeah, well, it's actually very easy to see. This gives a very high definition picture of the cornea, and you can see exactly there where the scleral spur is. It's easy to detect. And actually, when I would advise the colleague who asked the question, go to the CSO people, when it's back possible, and they can show it right away and we'll never miss it anymore. It's very easy to detect.
So would you advise to use the automatic feature or going individually to measure it? What is your advice?
At 95% of cases, I use the automatic. It's the machine is very, very accurate in picking the right spot for a scleral spur.
And this question reads, if you don't use white-to-white anymore, what value do you input in the calculator?
I do as I explained, the Nakamura formula, and in that formula, there is no room for white-to-white, so I don't use it anymore.
So basically what you're doing is just getting the sizing from the Nakamura, and you don't go to the Star Star website to order the lens, right?
Of course, to order the lens, you have to put it in, but then sometimes you have a discrepancy, and you can correct that, and you can take a larger size or a smaller size, depending on what you got with the calculation.
All right. I think there is a little bit of confusion yet as regards the Nakamura formula, the way it is designed. One of our listeners is saying, can you kindly explain it a little bit better or a little bit more in details? How is it done?
Well, there are 3 parameters. You have the scleral spur to scleral spur, which the variant and the relationship between sulcus to sulcus and scleral spur is much tighter than white-to-white to sulcus to sulcus. So this is the first measurement, scleral spur to scleral spur. Of course, the anterior chamber depth is important. The MS39 gives that number from the endothelium to the anterior capsule of the lens, and the lens rise. As you see, as the lens comes like this or like this, it will have an influence on your vault. So you have to take into account the lens rise in respect to the sulcus and the scleral spur, of course. So this is an extremely important value that you have to take into account. So the lens rise, when you have an eye with the same scleral spur and same anterior chamber depth with this lens rise, and only the lens rise changes with the same dimensions, you will get a much higher vault in the second eye with the other dimensions exactly the same. So lens rise is the most important parameter in this formula.
So this question comes from your very good friend Alaa, who is watching you. How much did scleral spur measurement improve the accuracy compared to white-to-white measurements?
Well, actually, I must say that the because I told you with the Aquaport, undersizing is not an issue anymore unless you have a toric ICL which rotates, then it is an issue. So we want to avoid over vaulting and angle closure glaucoma, which is of course a devastating complication. We could, in all my cases since I'm using the CSO, I never had an excessive vault over 1,000 microns. I had a few cases with 50 microns, a low vault, but that isn't an issue. So the accuracy went up to, well, let's say to 98% of my cases were perfect. 2% of the cases were or low or a little bit high, but still acceptable.
And another question reads, besides sizing, is there any other reason to perform an UBM on preoperative ICL patients, for example, to detect an iris cyst and so?
Well, I asked myself the same question a while ago. And in the beginning, I kept on doing UBM. And then once in a while, you detect an iris cyst. And then you think like, what am I going to do? Actually, I'm nothing. What I'm going to do? Nothing. I'm just going to put in the ICL and the same size ICL, actually. So after a while, I thought like, why still performing UBM? Because I'm after, at the end of the day, I'm disregarding the iris cyst which I detected behind the iris. And to be honest, iris cysts are not so common after all.
Right. Let's move a little bit on the clinical side. A question reads, if ICL is oversized, AC a bit shallow, but vision is good, patient is not complaining, what would you do? Follow up the patient or exchange the IOL?
Yes, so a couple of things I'm looking for. First of all, when you have an oversized ICL, it pushes a little bit forward and pushes the iris open, so you get a bigger pupil. So is the patient bothered by his larger pupil size, yes or no? So this is a discussion between surgeon and patient. Secondly, we measure the angle again with the OCT, and there we're judging when it is too narrow, we will exchange it, and when there is a risk of acute angle closure glaucoma. But in my opinion, when you have 15 degrees or larger, I will not take that lens out when the patient is not complaining of a larger pupil size.
That's a tricky question. Is a pentacam necessary if you own an anterior segment OCT?
In my opinion, I don't have a pentacam, and I have every data I need to do my surgery with the anterior segment OCT.
So that's a good spot for CSO, let's say. Does the relation between spur to spur and STS is the same either in short and long eyes?
For my experience, I did not look particularly into that, but from my experience for hyperopic eyes, I use the same formula, and our vault is very good with that as well. So I do not do a fudge factor for smaller eyes or longer eyes, no. Right.
One more, what is the least or the shortest size allowed scleral spur to scleral spur?
You put it in the formula, and the smallest ICL diameter is 12.1 millimeters, and depends on the limit is the diameter of the ICL, and then you as a surgeon have to judge whether this ICL size is suitable, yes or no. But otherwise there are no limits.
And this one is really the last one. You have some more questions that you may want to answer individually on the page. The last one that I'm going to read is if the measurement accuracy is affected with problems in the corneal, in the anterior corneal segment, or if you have a keratoplasty done, all of that.
Yeah. Depends on the image quality, exactly. So in these cases, I would advise you to go to the instrument and look for the scleral spur yourself. Are you comfortable with it? Use it. Are you not comfortable? Use white to white or UBM.
Very good. So Erik, you got a number of questions that it is not possible to follow. I mean, as soon as I cancel one because it's been answered, many more are popping out. So you have to do your job by yourself. And I'm going to, first of all, compliment with you. That was extremely nice. And the questions were appropriate and extremely useful as regards your answer. But it's time to move on. And thanks again. Our next speaker is going to be another giant in ophthalmology. In this case is Alaa El-Danasoury. We can say he's from Jeddah. Actually, he's not from Jeddah. He's from the entire Middle East, given that, I mean, he's the medical director of a huge chain of excellent laser and cataract surgery centers. Mohamed Alaa has a huge experience in all the anterior segment surgery, but he has always been very focused on cornea, both as regards refractive approaches and therapeutical approaches. So it's my pleasure to introduce him to you to show you how the combination of an anterior segment OCT and placido imaging can be useful for that purpose. Alaa?
Thank you, Francesco. Thank you so much. I'm really privileged to be with you on this webinar. Thank you for the nice introduction. And I'll also wanted to thank CSO for organizing this very interesting seminar with these very elegant, very good speakers, very good friends after all. So in my talk, what I'm going to do in this 20 or 25 minutes to come is to share with you the advantages of having a combination of two mature technology Here I mean the anterior chamber OCT and the Placido imaging. Now, these are my financial disclosures. I'm consulting for CSO, who is manufacturing the MS-39. Now, as an anterior segment surgeon and refractive surgeon, corneal surgeon, what do you need? You need from your imaging device, maybe the most important requirement is a device that helps you to select your cases for laser vision correction. I would say 50% of the imaging I'm doing is to exclude patients who should not have laser vision correction. Also, if you are doing phakic intraocular lenses, and as Erik mentioned very elegantly in the previous talk, you need to have an anterior segment OCT in order to choose properly your cases and in order to follow up your cases properly after surgery. Intracorneal ring segments now is a big thing, and many of us are using this. Having an anterior segment OCT is extremely important, and I cannot imagine doing intracorneal ring segment without anterior segment OCT. Though we were doing this in the late 90s, but nowadays I don't think you can or you should do intracorneal ring segment without having access to an anterior segment OCT. Also, in terms of diagnosing corneal opacities and corneal pathologies, having an anterior segment OCT with a good imaging system is very important and very crucial in your practice. Lastly, when you're doing, again, having an anterior segment OCT is very helpful to take the right to do any other technique for deep lamellar keratoplasty. And that's what you're going to go through in the next few minutes. Now, this is let's start with the laser vision correction. And this is the standard map. And as you know, corneal imaging went through many stages of innovations and improvement. We start with the Placido alone, then the Shampoo, and then the scanning slit, and then the OCT, and then the combination. So the standard map from the MS-39 gives you the four important surfaces that you are looking at, four important information that you're looking at. Of course, the anterior surface is very important, posterior surface is very important, and the corneal thickness map is very important. And on the standard map, you have the anterior elevation. Actually, in my practice, I do not look much at the anterior elevation. I prefer looking at the epithelial thickness map. And as you know, in the last few years, more importance was given to the epithelial thickness map, and having such a good, high resolution OCT in your hands will help you to look at the epithelial map and get some benefit out of it. So nowadays, these are four maps that I always look at. Anterior surface with the Placido, which is very accurate and very much more accurate than any other way of imaging, and we know this. Corneal thickness map with the OCT, posterior elevation map with the OCT, and the epithelial thickness with high resolution OCT. Now the MS-39 gives you other maps if you like to have a sagittal anterior curvature map, a Gaussian map, which I think will be important in the years to come, not yet very popular. You can look at the refractive curvature power and tangential posterior curvature map, which gives you good information. And there is an important image here that I always want to look at to see the Placido and the ring detection, the Placido rings and the ring detection, so you can tell if you have any artifacts on your image. Also, with the MS-39, you have a very elegant keratoconus screening tool that helps you to detect those early cases. And I always, 100% of my cases, every patient, every time I look at the keratoconus screening. It gives you the anterior surface deviation from normal, posterior surface and its deviation from normal, also the epithelial thickness and the deviation from normal, and the corneal thickness with the pattern deviation. And there is here in this little box a very interesting thing that maybe some of you didn't see before, which the cross-section of the applanated cornea. Now the cornea is applanated as if to put the epithelium in a straight line. Then you can see the back surface of the cornea and you can detect any little asymmetry on the posterior surface, which is important with early detection of keratoconus. Also, having the anterior segment OCT with good resolution, you can look at the angle, at scleral spur, as Erik just mentioned before. You can even see the wound of your cataract surgery. If you want to look specifically on the cornea, like in corneal dystrophies or degeneration, then you have high resolution corneal images. And this is the applanated cornea. As I mentioned, you can see the epithelium very clearly, the Bowman's layer, and you can also see the posterior surface if it shows a little bit of asymmetry like in this case. Now, let's focus in the next few minutes on the selection of patients for laser vision correction. So what do we want to do basically is to exclude those patients who have a very early keratoconus or are prone to develop ectasia after laser vision correction surgery. This case is a definite keratoconus. No one will argue. There is no debate here. Here, I just wanted to show you in a clear case of keratoconus, you're going to see matching with the four maps. So the anterior surface show definite steepening, the posterior surface show definite elevation, the corneal thickness show definite thinning, and the epithelial map shows clear thinning of the epithelium over the apex of the cornea. So there is no challenge in this case, and you can actually diagnose it maybe on the slit lamp without even a topography. But the challenge comes with such cases, especially over the last 10 years when the Schempf look became kind of the golden standard for a while. Everyone was looking at the posterior elevation as the solution for corneal refractive surgery. And in many instances, some surgeons that I know look only at the posterior elevation. Now, it is correct, of course, no. You should not look to the posterior elevation only. And this case is a good example. Here, the posterior elevation is normal, nothing abnormal. Corneal thickness is normal. But if you look at the anterior topography, you will see some, again, the rural astigmatism with some sagging, what we call before like laser. So is this an early keratoconus? Is this an artifact? Is this because of some tear film instability? I would say this is definitely an early case of keratoconus. And if you are in doubt, look at the other eye. The other eye shows a clear keratoconus on the posterior surface as well as on the anterior surface. So this patient did not show early keratoconus on the back of the cornea, but it showed the earliest sign of keratoconus on the anterior surface of the cornea. So from this case, we learned that anterior surface is very important. It's not only the posterior surface, but it has to be anterior surface included. Another case where the posterior surface shows a very normal elevation, while the anterior shows early keratoconus. If you are in doubt and you don't believe the anterior surface, look at the other eye of the same patient. This is a definite keratoconus. So I showed you now two examples where the keratoconus can be detected first on the anterior surface as opposed to the posterior surface. On the posterior surface, absolutely no. Now, would we say that the posterior surface is not important? Of course not, because in it's vice versa. You can always find cases. I have many cases where the keratoconus become manifest first on the posterior elevation. So this case, for example, shows a clear keratoconus on the back surface. The anterior surface is kind of equivocal, question mark, a truncated bow tie, but you can pass this as normal. But on the posterior elevation, there is definitely an early cone. Another case where the anterior surface does not show much of change, while the posterior surface shows a clear keratoconus. So the question is not anterior surface is more important or posterior surface is more important. The answer is it's both of them. It's not posterior or anterior, it's posterior and anterior. Now, with the Scheimpflug imaging that we have been using for a very long time, and it did very well for the last decade, but now I think it's the time for OCT. And the question is, does the Scheimpflug give the same posterior elevation data like the OCT? The answer is no. Look at this patient, for example, on the Scheimpflug, he has, this patient has a definite high elevation, but on the OCT, the posterior elevation is normal. And this patient had LASIK more than 2 years ago with excellent outcome. Now, the epithelial map, lot of talks and speeches and presentations and publications on the epithelium over the last 10 years or so. Now, with the MS-39, you have a very good, very elegant epithelial maps. And is it really very important? I would say the epithelium is, looking at the epithelial map is very important, but it's not alone. You cannot use the epithelium alone to diagnose a keratoconus. It gives you a lot of added value. And in some cases, it draws your attention, like in this case, for example, where the anterior topography is kind of normal, posterior topography is normal, but you have a thinning on the epithelial map. And the other eye of this patient shows a definite keratoconus. So in this patient, the first sign of ectasia could be detected on the epithelial map. But is it helpful all the time? Well, look at this patient, definite keratoconus anterior and posterior, but the epithelial map is absolutely normal. So there is nothing to worry about if you look at the epithelial map only, but anterior and posterior maps show a clear early keratoconus. The same here, a definite keratoconus and the epithelial map shows actually thickening. So the epithelial map is a very helpful tool. It should not be your first line of first way to diagnose, but it gives you lots of added value. And I'm sure with more experience, we are learning every day, and we're going to make more use of the epithelial maps. Now, the fourth parameter is the thickness. Now, the corneal thickness, you know, the keratoconus is a degeneration where the first thing that happened that the cornea gets thinner. And so measuring the thickness is extremely important with if you're dealing with keratoconus patients. Now, comparing the corneal thickness measurement with the OCT versus Scheimpflug, I have this interesting case. This patient had cross-linking. So on your left-hand side is the corneal thickness measured with the Scheimpflug before cross-linking. On your right-hand side is the same patient 3 months after cross-linking. And here is the differential map, which shows a 35 microns of thinning after cross-linking. Is this strange? No, actually, you find this in almost every publication on cross-linking over the last 10 years. It shows you thinning of cornea after cross-linking, and all of them measured the corneal thickness with the Scheimpflug. And I'm sorry to tell you that this information is not correct. This is, I can show you the next slide. This is the same patient, the same eye, examined on the same day with the OCT. This is the pre-cross-linking. This is the 3 months after cross-linking, and this is the difference in thickness. So the difference in thickness in the same patient on the same day with the OCT was only 8 microns. So the thinning that is happening after cross-linking and is being published in maybe hundreds of papers may not be very accurate because the measurement was done with the Scheimpflug. If you do the measurement with the OCT, you get totally different results because of the scatter. The Scheimpflug is an optical way to measure the thickness, and it is much affected by the scatter that increases a lot after cross-linking. So this was a red flag to me. I learned this many years back, and since then I do not rely on my Scheimpflug measurement in any thickness. Now let's move to the intracorneal ring segments, and I started doing ring segments in the late 90s, 1998, 99, with Joseph Collin, our dear friend, the late Joseph Collin, when he introduced the intacs for cross-linking. And I'm not very much fond of the intracorneal ring segments, but it is useful in very specific particular cases. And if you are doing intracorneal ring segments, you need to have an anterior segment OCT to assess your cases post-operatively. In this case, for example, you can tell that the surgeon here, which is myself, did not do a good job here because the ring is kind of superficial as compared to the other other rings. So in order to achieve good results, you need to have symmetrical placement, like in this case, for example. Now, but what I want to draw your attention at is something different today. The effect of intracorneal ring segment had been known to be flattening of the cornea and to some extent strengthening of the cornea or change in biomechanics of the cornea. Now, what I want to draw your attention here using the epithelial map of the MS39, that with the intracorneal ring segment, the main change that is happening is, of course, flattening, but flattening is due to the increase of the epithelial thickness. So if you look at this patient, for example, he had a corneal ring segment here, an extensive flattening central to the ring. If you look at the epithelial map, you're going to see clearly how the epithelium is thicker central to the ring. And this is the main reason for flattening and the induced hyperopic shift or some correction of the astigmatism or whatever. So it's not the change of the biomechanics of the cornea as much as the change of the epithelium of the cornea. And you can see this clearly here. This is the intracorneal ring segment. And you can see the thickness of the epithelium near the segment is much thicker than the epithelium on the opposite side. So one of the major changes that happens after intracorneal ring segment is the increase in thickness of the epithelium, and this is the main change, and the flattening is secondary to the increased thickness of the epithelium, and the refractive change that happens after the intracorneal ring segments is also secondary to the change of the epithelium. At least the epithelial thickness change is the major effect of intracorneal ring segments. Another example of the case with the intacs, in this case, 2 rings, and you see the extensive thickening of the epithelium central to the ring, which ends in relative flattening central to it. Of course, if you're using Scheimpflug imaging, you don't see anything. You hardly see the segment because of the scatter. Now, moving to post-operative assessment of refractive surgery patient, if you're doing laser vision correction, then you have this patient who had LASIK like 10, 15 years ago, especially if it's not done in your place, you don't know the thickness of the flap, you definitely need to know the thickness of the flap. With the MS39, you can get accurate measurements of the flap thickness down to up to 15, 20. I've seen patients 20 and 25 years after LASIK, and we could very clearly measure the thickness of their flap with the MS39. Here you can see very clearly the epithelium, bones there, and the interface, and you can measure the residual stromal bed and decide whether you want to do enhancement or not. Same for the smile cases. With the smile, you'll see more irregularity, as you can see here, more irregularity of the Bowman's there because of the nature of the procedure. And that's why the recovery, the visual recovery after smile is somewhat delayed compared to LASIK because of this micro irregularity on the in the Bowman's layer. Now, I'm not going to talk about the phakic intraocular lens that was elegantly covered by Erik. You can get some information from the Schimpf loop, but with the OCT you have more information, like the crystalline lens rise, scleral spur to scleral spur, and anterior chamber angle, which are important for better sizing. Now let's move to the last section of this presentation, the corneal surgery. I wanted to share with you this image, which was very impressive to me. Actually, this is a patient of mine who had bulk surgery before the Corona era, and then he lives in a different, in a far city, and he could not come for his 1 month follow-up. So he sent me this picture. I found very interesting because it's kind of corneal topography, it's corneal imaging. And the patient was smart enough to take his image in front of his picture, in front of the window, and you can see the reflection of the window on his cornea. And when I saw this image, he sent it to me on my smartphone. I told him, okay, you don't need to come back for corneal imaging because you already did it and you have a very good outcome 1 month after the surgery. So I cannot imagine myself doing corneal surgery without having an anterior segment OCT. And since I had MS-39 more than 3 years now, I would say this is the most important piece of instrumentation in my practice now. If you're doing DZAC cases, like in this case, it's important to have an early image after the surgery to check the adherence and the stability of your disc. In early post-operative DZAC, you might see some separation, some detachment of the disc, like in this case, that cannot be easily seen or on the slit lamp because of the corneal edema on the early days after surgery. So in this case, for example, you might decide to go and do rebubbling in order to close this gap early after surgery. If you're preparing your disc yourself, then you want to know the quality of the disc. In this case, the DZAC disc is more, it's thicker on this end and very thin on the other end. So this is not a planar cut, and this will end in a refractive change of the patient. If you're getting your corneal DZAC tissue from your eye bank, you need to know the quality of the cut. So in this case, I am not happy with the profile of DZAC disc. Of course, with Schimpf loop, you don't see much. 1 week post DMAC, early separation, then this patient is for rebubbling, and this is 1 day after rebubbling, the descent is totally detached. So having early on anterior segment OCT after corneal surgery is important. If you have a patient with a Fuchs dystrophy and you're not sure whether he needs a DMAC or PK, with an anterior segment OCT, you can assess the amount of corneal edema and whether this patient really needs a PK, but in most of the cases, DMAC is the procedure of choice if you don't have corneal stromal scarring. If you're doing bulk surgery, you have to have an anterior segment OCT. I'm doing this as a routine in order to know whether any scarring is reaching the descent level, because if it is not reaching the descent level, as in this case, then you can easily get a big bubble and have a very safe surgery. But in such a case where the scarring reaches the descent membrane, you know that you're not going to have a big bubble, then you might prefer to do any other type of lamellar graft, like manual dissection or Melis technique or any other technique. Post-operatively after bulk, a total detachment of the descent, very clearly seen with the OCT. Then post-air injection, you can assess the reattachment. You can assess the graft-host junction after corneal graft, so you know if this is the reason for astigmatism, if you need any wound revision, and so on. Of course, with the sham fluke, you don't see this. Granular dystrophy, you can assess the depth of the lesion, whether this patient can benefit from PTK, like in this sub-epithelial scarring after adenovirus. You can see the irregularity at the level of the Bowman and sub-epithelial stroma. And this is 1 day after PTK with still the contact lens on, and we got rid of all these irregularities of the patient. This patient, I see him recently, 80 plus years old. He was referred to me for penetrating keratoplasty. His general condition was too bad, and he had this central scarring with the OCT. I could realize that there is a secondary Salzman nodule, which kind of superficial. The rest of the stroma is relatively okay. So instead of doing a PK on this 87 years old patient with poor general condition, we did a PTK, and we restored a good amount of corneal clarity. I would do this if I had no access to an anterior segment OCT. The last thing I'm going to show you here, this interesting cases, I've seen her recently. This patient was scheduled for laser vision correction somewhere else. She had myopia. Then she came to me, I did the imaging, nothing really special. But if you look at the lens, you can see here a clear lenticonus. That's an anterior lenticonus. This image shows it even more clearly. So this patient, the myopia is not due to an axial myopia, it's due to the anterior lenticonus, and she actually has a little bit of anterior cataract. So if you do any laser vision correction on this patient, then you are really jeopardizing her future refractive refraction after surgery, because 1 day she will have this lens extracted and then she will have a severe hyperopia. So having the anterior segment OCT gives you a full picture of the anterior segment. It's not only the cornea. So to summarize, today I believe the anterior segment OCT with the placebo technology combined together, this is the way to go. It gives you very accurate measurement of the anterior surface, the posterior surface, the corneal thickness, even in the presence of scatter or scarring. It gives you the epithelial map, which has an important role in today's diagnosis. It gives you additional information, the angle to angle, the angle size, the Spur, the crystalline lens, rise, and the tilt of the anterior chamber of the IOL inside the eye. It gives you accurate measurement of the post-LASIK, post-SMILE, post-intracorneal ring segment measurement. And also it gives you a very good assessment of any corneal pathology or post-corneal surgery. So I cannot really imagine myself doing any kind of anterior segment surgery without having this technology, the combined placebo and anterior segment OCT. I have no doubt that this is the way to go. This is not the future, this is actually the present. And I know that many other companies are now following the same path of CSO, few years behind, but I have no doubt that this is the way to go in the future. And I thank you for your attention.
Thank you so much, Alaa, for this great presentation. We have time for a few questions. The first one is, let's say, comparison in between Scheimpflug and OCT. The question reads like, can you rule out keratoconus as accurately on OCT as with the Sirius? But you obviously can extend the answer to the relationships that you find now in between anterior segment OCT and Scheimpflug cameras.
Well, actually, that's very, very good question. And I've been using Scheimpflug. Scheimpflug was the golden standard for the last decade. It was very good for the decade. But today, I think the Scheimpflug technology will not have much of the role in the next 10 years. For the last 3 years, I'm doing Scheimpflug and OCT for all my patients. I had the Pentacam. I used it for many years, and on all my patients, I'm doing Pentacam and MS39, and I'm comparing the results. And I can confirm that with the OCT, you can detect cases that cannot be detected with Scheimpflug, and with the Scheimpflug, you have some false positive results that shows to be absolutely normal with the OCT. When it comes to patients with scatter, like post-cross-linking, or patients with some corneal opacity, the Scheimpflug is totally blind. You cannot rely on it. A good example, as I mentioned, after the cross-linking, measuring the thickness with the Scheimpflug is absolutely wrong. You cannot rely on this. The only thing that we have thousands of cases measured with the Scheimpflug, but the right way, the correct way to measure the thickness is the OCT and not the Scheimpflug.
Thank you, Alaa. In order to maintain our timing, two quick answers to two questions. So first of all, it is not really clear how the applanation is acquired, and I think this is the reference to the image where the cornea is made flat. Do you want to comment on that?
Well, it's just another way to look at the cornea instead of having a reference to the best fit sphere or the best fit toric ellipsoid. We are kind of imagining if we can flatten the cornea, the anterior surface of the cornea, so the epithelium is kind of flat, like straight line, and then you look at the posterior surface, and this gives you a better view of the asymmetry. So this is still something new that we have to work on for the next few months, but it's very interesting and very promising.
Last question that opens also the next presentation is if you find that the demarcation line in post-cross-linking corneas to interfere with the quality of the OCT readings and measurements.
No, not at all. With the when you are using the OCT, the scatter that increases after the corneal after the cross-linking, it does not affect the measurement with the OCT. It does with the Scheimpflug. It does with any optical way of measurement, but not with the OCT. So
again, thank you so much. We're going to move on. There are a couple of questions that you may want to answer individually, typing them in the Q&A area, Alaa. Some of these questions can be also answered by the CSO staff because they are more like technical or related to the software releases and so. It is my pleasure now to introduce you with another, prominent ophthalmologist. There are not a lot of words to describe Farhad Hafezi, especially as regards his huge job regarding cross-linking. I am sure that Farhad is going to remember today, because of the ticket he's going to get driving so fast to Geneva to make the meeting. So we apologize for this ticket that you're going to get. On the other hand, we are very happy to have you here. And I'm sure that the topic that you're going to cover, let's say slit lamp cross-linking, is going to be of great interest. So thanks again for making it.
Yeah, dear Francesco, thank you very much. And hello, Alaa, also. Thank you for the announcement. And I regularly follow you on Facebook, and I'm happy to see you in good health and morale. And let's go through this together. So I will now switch to my topic. Let me just see whether I have the screen. Share screen is on. Yep, I just have to choose the right desktop. And now you should be able to see my screen. Is everything okay?
Perfect. We see it clearly.
Fantastic. So as you said, Francesco, I will speak about cross-linking at the slit lamp under these two aspects and indications, keratoconus and keratitis. First of all, these are my financial interests for this topic. Now, if you look at cross-linking for keratoconus, then I'm sure we all agree the keratoconus indication is established. It has become a standard of care. We have CE mark and FDA approval, and a lot of procedures performed every year throughout the entire world. And we also know that ever since cross-linking for keratoconus came up, the number of corneal transplantations has dropped quite drastically in countries that have a central register, like, for example, the UK. Now, the second indication is keratitis. And as many of you will wonder, well, how come that you can establish a technique like CXL for keratoconus, and all of a sudden it also works in infection? Well, please let me show you this slide. And you should remember that in every CXL procedure, you do not only stiffen the cornea. This is effect number one, biomechanical stiffening. In fact, you do three more things in every CXL procedure. You stiffen the cornea, then you increase the cornea's resistance against digestion. And effect number 3 and 4 is you kill everything that lives on and in that cornea by intercalating with the DNA or RNA or by pure oxidative stress. So as a reminder, if you perform a cross-linking for keratoconus procedure next week, you will do all 4 effects at the same time. But what you're most interested for in keratoconus is number 1 and partly number 2, because keratoconus also has some enzymes, MMP9, going on. But at the same time, you also disinfect this cornea and you kill all keratocytes and any bacteria living on it. And this is why cross-linking is a principle, a physiological principle in the cornea, and you can also adapt it for keratitis. Now, when we started looking into keratitis some years ago, we realized this is a different ballgame than keratoconus. This is not a relatively rare disease anymore. It is one of the leading causes of global blindness, with millions of new cases per year. It affects many people with severe visual impairment and even blindness. And one thing that is extremely hard and will get even harder in the next years is antibiotic resistance. If you look at the WHO and its numbers, the WHO tells us in the whole field of medicine, by the year 2050, more people will die by antibiotic resistance than will die by diabetes and cancer put together. And this means, if you translate this into ophthalmology, the resistance for corneal infection, for corneal infections goes up rapidly. So in a few years, our fancy 4th generation quinolones will not work as effectively. So any method you have that is independent of antibiotic resistance is very useful, and cross-linking is independent of antibiotics. And lastly, if you are a very experienced corneal specialist, it might be a little easier for you, but it doesn't move forward. Let me just check why here. But if you are relatively new in the field with 2 or 3 years of experience, then making the difference between a bacterial infection, a fungal infection, a mixed infection is not that easy. When conventional medicine, you have to decide, what do I give? In cross-linking, you kill both. You kill fungi and bacteria at the same time. And lastly, in many instances, the normal treatment of infection is a huge cost-related problem. And I'm not talking about medication. Medication is inexpensive in many countries. It's us. It's the optometrists, ophthalmologists, all eye healthcare professionals that see patients. So if you are in remote India, the patient might come to you once, but not 2, 3, 5, 10 times in the follow-up of a corneal ulcer, simply because the patient has not enough money to do so. So we started looking into this new indication, and the very first paper on infectious keratitis came from our group back in 2008. This was a pilot, a promising pilot. And a few years later, we decided to find a new term, not call this CXL, but rather PAC-CXL, just to make the difference in publications and when we talk about cross-linking. PAC stands for photoactivated chromophore for keratitis, cross-linking, PAC-CXL. It was a Swedish colleague, Mertens, who took this to the next level. in 2012, because he was the very first to publish data on cross-linking alone. So no combination with medication, only cross-linking. And he did this in 16 cases of corneal ulcers. And what he did, he took the Dresden protocol that was established for keratoconus, and he simply irradiated with the Dresden protocol in these 16 eyes. And as you can see here, this was the moment when we all realized, ooh, this really has the potential to change the way we treat corneal ulcers. Because if you can treat such an infection without a single drop of ofloxacin, without moxifloxacin, just light and vitamin B2, then this is quite exciting. Out of these 16 eyes in this phase 2 trial, 14 eyes needed no additional treatment, just cross-linking. 2 eyes needed more antibiotics. So this was exciting. What we have started then, we were enthusiastic and said, let's try in big ulcers. So we did a collaboration with Egypt, with the Institute of Research in Ophthalmology, IRO, and we attacked the very big ulcers. Just to be a little disappointed, this was 6 years ago. We tried huge ulcers with the Dresden protocol, 7.6, 7.4 ulcers in the control group, so very far advanced. And here we looked at the time to healing, and as I said, a little disappointing because the time to healing was not very different. Still, I think it's a good idea to use cross-linking here because you make the tissue more solid, a little more resistant against digestion, which always is a good thing for the final scar. But we realized we were too enthusiastic, going too big, too quick. So in the next years, we did 2 things. We thought, okay, let's not try with the huge ulcers. Let's go smaller again. And maybe we can modify the technical settings. Maybe 5.4 joule and Dresden protocol is not enough. And maybe we can make the whole thing faster, like we do in cross-linking. So this is what we did over the next years. Instead of applying this protocol in huge ulcers with no big difference in time to healing, and let me show you some examples of ulcers. This is what we tried. So you can imagine these were impending perforation ulcers. So we simply were too enthusiastic, but still it certainly solidified the tissue, which is an advantage. We had less perforations in the cross-linking group in these very far advanced cases. But again, as I told you, in the years after, we tried smaller ulcers and we tried to accelerate. You may know that if we look at keratoconus, we can accelerate in a certain range. Our group published the oxygen data and published accelerated cross-linking. And we saw that a moderate acceleration from 30 minutes to 10 minutes, yes, that works for keratoconus. We cannot go faster because of oxygen limitations, but we did the same thing for infections a few years ago. And here you can go faster. You can go to 150 seconds, 2.5 minutes with very high intensity without losing efficacy. We published this 6 years ago already. Why? Oxygen independent, partially independent. So at least within this range of intensities, yes, you can go very fast. Let's look at the clinical data. We went really fast and we went into smaller ulcers, and this is where things started looking very different. So this is a study that has just been published in the JRS with our friend Boris Kneiser. This was Elsa and Boris University in collaboration. And what we did, we compared 2 groups. We looked at antibiotics and antifungal only in 41 eyes, small ulcers, well, not so small, but 3.2 in average. And we compared to almost same size with accelerated. You see, this is not Dresden, this is 10 times faster. 3 minutes with 30 milliwatts. Still, the total energy is the same as we usually have. That's the upper right, 5.4. And here we had a very nice result, much faster time to healing, significantly faster time to healing, which means less follow-ups, less aftercare until a higher probability of healing the ulcer without losing the patient in the follow-up. And then at the same time, we did a collaboration with Egypt, with Mohamed Hosni, same protocol, same setup, a little bit bigger in ulcer size. So we went, oh, sorry, these are the results from Israel. Now let's go to Boris Kneiser. And here we went a little bit bigger with the same setting. So we went to 5 millimeters, from 3 to 5. And we had one group with antibiotics, one group with antimicrobials, antibiotics, and cross-linking, accelerated cross-linking. And again, significantly faster in the healing, but because this was already much bigger, the healing just takes more time, but significantly less time when you do additional cross-linking. That's good. But the best way to show that PAC cross-linking really has a place in the arsenal of methods in infection is a prospective, randomized, multi-center, masked controlled trial, and a proper RCT according to FDA standards. Only cross-linking against only antimicrobial medication. We did this. It took us almost 4 years, and the data are ready to be presented at this year's Academy and ESCRS if we are lucky enough to go there. So what we did, we looked at mid-sized ulcers up to 4 millimeters, randomized. Patient comes in and either is allocated to cross-linking only or to medication only. And then the patient is followed every 24 hours. If you had cross-linking, all you get is vitamin A, no antibiotics. But if you get worse, after 1 day or 2 days, it's a treatment failure and you need medication. That was the setup. We implemented several countries, several geographical locations, so different types of ulcers, bacterial, fungal, and mixed. China, India, Egypt, Israel, and Switzerland. The study is finished. What we did, we had 23 eyes with small to mid-sized ulcers in medication only. And we had 23 eyes with accelerated high fluence cross-linking. So the big difference to the other studies is not only accelerated, but you see in the upper right, 7.2 joule. So more fluence. And what we found there is very encouraging. First of all, look at the small percentage. We had healing with PAC cross-linking in 87% of cases. No significant difference to antibiotics and antimicrobials. So one single treatment was enough to stop the entire process. And the difference in time to healing was not significant. A little longer in PAC cross-linking, but no significant difference. In other words, PAC cross-linking alone has the potential to heal the cornea completely. And let me show you an example. For example, this is a case that was treated with light and vitamin B2 alone. Now, do not misunderstand me. I'm not saying to leave antibiotics for now. No, this was a trial to show the isolated effect of PAC cross-linking. In the future, I will always use it together with antibiotics in ulcers, but it shows how effective PAC cross-linking is. And who knows, someday we might really use this as a full standalone in small ulcers. For now, because it's a new method, please continue using your antimicrobials, but your time to healing will be much faster. So this is where we are standing with keratitis. For keratoconus, you all know the current standard of care, but I have one exciting piece of news to share. You may remember that we introduced the swelling of the cornea in very thin corneas, so hyperosmolaric treatments 12 years ago. And this is a way to treat very thin corneas, but the treatment method has limitations. And I'm very happy to tell you that now we are able to treat down to 220, even 210 microns of stroma. And this was impossible with any of the other thin cornea methods to date. We've been working on this for 4 years also. And let me just show you very briefly in 2 minutes what we have done. These are the methods in current use for thin corneas. Our initial swelling of the cornea, Susan Jacobs contact lens assisted, and Cosimo Mazzotto's epithelium island method. although we invented swelling, we don't really like to use it anymore. Why? It is unpredictable. Some corneas swell tremendously, others less. Susan Jacobs' method sounds very convincing, but has one issue: oxygen diffusion is limited. So we published, and Gregor Waldensack published, if you use a contact lens, your efficacy drops by 30% in biomechanics. And Cosimo Mazzotta's method is also sometimes problematic because you have a haze, a pattern of haze over the areas of epithelium and no epithelium. So instead of modifying thickness, all these methods modify the thickness of the cornea. We started individualizing the fluence, which means depending on how thick the cornea is, only the stroma, we adapt the fluence in every single patient. This is not customized cross-linking. This is individualizing one uniform fluence over the entire cornea. We've been working on this since 2015. We have published the algorithm in 2017, so this is public knowledge. And we are presenting our data at this year's ESCRS. We have performed a prospective monocentric study with 47 eyes and 1 year follow-up. And the thinnest we've treated was 214 microns. Extreme cases of Kmax readings of 80 diopters and more. No endothelium decompensation, no damage, and a demarcation line exactly where we need it. So this is the exciting news for keratoconus treatment. Now, I will spend a few more minutes on cross-linking at the slit lamp because you have all the pieces together now. Now, if we can be very fast in keratitis treatment and relatively fast in cross-linking treatment, this is nice. But the main problem is we do this for people who have access to an expensive infrastructure. Everything we have developed in the past 15 years is for the few percent of the global population that can afford to see modern ophthalmology. What about all these patients out there that are in remote areas and have no access to an OR, and the next ophthalmologist is 50 kilometers away? We need to democratize the access to cross-linking, which means our vision is going out of an expensive infrastructure into an inexpensive infrastructure. Let me show you why. If you are in a country with good infrastructure, you might want to do this because it reduces costs. You can separate your infectious cases from your cataract surgeries in your OR, and you can have one device for several locations. If you are in a country with limited infrastructure, India is a good example, highly developed cities, but then very remote areas with no infrastructure. You can serve remote areas, you can increase the coverage of the method, which means access to all, democratizing cross-linking. So let's play devil's advocate. Let's look at this through the eyes of a skeptic. Well, we have obstacles, right? How can you stay at the slit lamp for so long? And what about infection? Well, the slit lamp, the time spent at the slit lamp, I just responded to. Nowadays, we have really good protocols already now for 10 minutes at the slit lamp. So I would not treat a child at the slit lamp, but a young adult who can sit for 600 seconds, yes, I would treat at the slit lamp. As for puck cross-linking, we are down to 3 minutes. That's totally feasible, 180 seconds at the slit lamp. So I think the argument of time is being taken care of. What about the risk of infection? Remember my first slide? With every cross-linking procedure, you disinfect the cornea, whether you do keratoconus or keratitis treatment. In other words, if you have a young mother coming in telling you, doctor, my toddler scratched my cornea, it is hurting, could you help me? Well, this cornea is more infectious than a cornea at the end of a CXL or PAC CXL procedure. So why should I take this infectious cornea into my into an antiseptic operating theater? It doesn't make sense. Treat him at the slit lamp. So the risk of infection is not really an argument for me. When we realized this, we looked at what do we want in such a machine, a slit lamp cross-linking machine. We want it to be mobile, lightweight. Ideally, I should be able to take my iPhone or Samsung charger and charge it with my charger. If I forget my regular charger, I should be able to charge it with a power bank. I should be able to use it at the slit lamp and in the operating theater in both ways, sitting or lying position. It should cover all the intensities. It should give me continuous light, pulsed light. It should be prepared to do iontophoresis assisted epi on pulsed cross-linking or Dresden protocol, and it should be inexpensive. Now, we've created the spin-off of the University of Geneva. Niki Hafezi is the acting CEO. Rolf Schwind from Schwind iTech Solutions is a member of our board, besides myself. And this is the Medical Advisory Board. And after some years of development, we are very happy to announce that we have received the CE mark for the CI device. Access for all, using cross-linking at the slit lamp or in the OR. So oh, sorry for that. Now I hope you can still, yeah, the microphone is still on. As you can see, we cover the entire range of intensities, 3, 9, I'm missing 15, 15 should be in there, 18, 30, and 36 milliwatts, continuous and pulsed light, with an optimized beam profile that gives more intensity in the periphery and fully battery operated via USB-C. So you can use it the modern way at the slit lamp. And as you can see, I'm mounting it there. It's very easy to mount. You just use the standard support of any Hub Stride type or Zeiss type slit lamp, and then it's held in place by a very strong magnet. Or, as you can see here, demonstrated by Matteo Marcacci from CSO. This is a wonderful collaboration with CSO Italia, who produces the device. You can use it the normal way, as you do with any other cross-linking machine. For the convenience of the user, we have integrated many different protocols, like the Dresden protocol, accelerated 10 minutes, accelerated 5 minutes. This is all keratoconus treatments. Then we switched to keratitis treatments with high fluence in 4 minutes. But then we are also ready for iontophoresis assisted pulsed cross-linking. This is the Mazotta protocol, which I find very, very interesting because you do not need additional oxygen. Here is another pulsed high fluence accelerated cross-linking protocol for epi-on. And finally, what I told you about these extremely thin corneas, you will be able to use the sub 400 protocol for extremely thin corneas with every machine. We did not protect this. This should be public knowledge, but our device has the whole algorithm integrated. So you do not have to look for intensities. It's all in there. You indicate the thickness of the cornea. The machine does the rest. The machine comes with a surgical pack with a sterile cap that protects the interface between eye and the machine. It comes with a speculum and our own riboflavin. We have developed this riboflavin with Eberhard Spur. One solution for all. You can use it for epi-on, for epi-off, and for iontophoresis assisted cross-linking. There really is no reason to have so many different variations of riboflavin if you handle the components carefully. One question we get a lot, sorry, I'm almost done. One question we get a lot is, isn't there a problem with riboflavin distribution because patients are sitting? This was easy to check. We checked on this and we published this some years ago. Short answer, no. You have 1 hour of time in the vertical position before you can measure any changes in riboflavin concentration. So in conclusion, slit lamp assisted cross-linking will be affordable. It will increase coverage, serve underserved remote areas. It will give advantage for high-tech settings or for very low-tech settings, and it will democratize the access to cross-linking technology. Thank you for your attention. Sorry for running late.
Thank you very much, Farhad. It's always nice to see scientists like you running late.
I'm afraid I can't hear you, Francesco.
Do you hear me?
I cannot hear you. Oh, or is it me?
I can hear you. Do you hear
me? It was me. Sorry.
I was just going to say that it's always a pleasure seeing people like you running late and hearing voice from scientists. So we are really grateful for your presentation. And there are some questions that I would like you to address. The first one is PAC cross-linking effective in acanthamoeba keratitis.
Not for now. I wouldn't use it for now in acanthamoeba, but the combination of riboflavin and UV light in other instances in solar disinfection kills acanthamoeba cysts, but it's a question of total fluence. Our fluence is too low for the moment.
On the practical side, one question says, would you put a contact lens after cross-linking for an infection?
Yes, I would put a contact lens. I would put a lens soaked in for example, fourth generation quinolones over the eye until the next morning. Yes.
And another question writes, what do you think about M nomogram cross-linking?
Yeah, that's a very good and important question. And I had a slide prepared, but I was running late. So what my friend Cosimo has done, he has also developed a protocol for thin corneas. The difference is easy to explain. If you look at Cosimo's protocol, he has taken all the published solid data of the last 15 years, and he has looked how deep do these protocols go with demarcation line. So some go 200, others go 250, others go 300. And he plotted them all. And then you can see, if I need a demarcation line at 240 because my cornea is only 280, safety, then I should use, I say something, 15 milliwatts pulsed and so on. So you can see exactly what you need. Our approach was different. We started from the scratch and we said, this is the thickness of the cornea. We develop a formula that respects oxygen diffusion, riboflavin diffusion, and we individualize the fluence. So I think these are two ways to roam. The advantage our method has, I think, is it keeps it simple. If you have a very old device that can only do 3 milliwatts, you can do everything with our protocol. With Cosimo's access, which is certainly very good, you need more sophisticated technology. You need a machine that can deliver everything because it's so many different protocols. With our machine, 3 milliwatts or 9, that's all you need.
And another question says, what exactly is the cross-linking profile for treating keratitis? The meaning is in terms of time and energy power?
Yeah, for now it is 30 milliwatts for 4 minutes, which is accelerated and high fluence. It's 7.2 joule. But we are starting a prospective study now with 10 joule because the latest data from the Zeiler group have shown that the old assumptions of Spur and Zeiler about how much energy damages the endothelium, they were too low. We can go much higher without damaging, and customized cross-linking already goes to 15 joule. So we will go up to 10 and then even higher. And we just published a cornea paper in vitro. And when you go from 5 to 7 to 10 to 15 joule, your efficacy almost goes to 100%, from 70, 80 to 100. So we can still, we have still a lot of room to make the treatment more efficient.
And can you comment on the effectiveness in fungal ulcers?
Yeah, in bacteria, we are between 80 and 99. In fungi, and we tested Candida and Aspergillus, we are lower. We are around 60 to 65 right now, but these are still 7.2 joule data. Right now, we are looking also into going into high fluence for fungi, and we are quite confident that the killing rate will go up.
Any experience using cross-linking in herpes simplex virus keratitis?
Little experience and disappointing experience for now. If you have a clinical suspicion of viral keratitis, herpes, please don't use it. But again, if you look at solar disinfection, you can kill herpes simplex virus, but the fluence is very high. It's around 40 to 50 joule. So for now, I wouldn't. Yeah.
And as regards sterile resistant recurrent epithelial erosions, any role for coronal cross-linking?
Besides PAC cross-linking for infection, there is a very interesting paper from the year 2000 where cross-linking has been used for sterile melting. And it is effective because of the steric hindrance and the inhibition of MMP9. But unfortunately, ever since there was no major study set up to test on this. We tried with Jose Alvaro Gomez and Reza Dana for Stevens Johnson, but we didn't get ethical committee clearance. So somebody should look into these peripheral rheumatological or systemic disease-related sterile meltings.
That's another very interesting question. How long would you wait to repeat cross-linking for keratitis?
If I see two things, I wouldn't wait very long. If after 2 or 3 days you didn't see that it worked, I would do it again immediately. Why? Because we know that the total energy will not harm the endothelium. Plus, you work in a cornea that is swollen, edematous. So anyway, the transmission of light is not that high. And lastly, we have treated quite a few cases of fungal keratitis twice within 48 hours. And we had good results. So it might also play into some immunological response. So for now, it's not an official recommendation, but if you have a clear case of non-response and you stay with 5.4 joule, you may want to try it a second time with 5.4 very soon after.
All right, Farhad. As it happened with the other speakers, the questions are running faster than the answers. So if you can answer at least some of them, typing them, that would be very appreciated. I have to move on to the last presentation that is going to be delivered by myself. But again, thank you so much for this outstanding presentation.
Thank you very much, Francesco.
And what I'm going to present you this afternoon is something different because it does not involve either anterior segment OCT nor let me go back on that, nor the cross-linking. I'm going to give you a different view of an instrument that I like quite a lot, that is the Osiris Aberrometer, and in this case used for purposes that you may not imagine to use, like analyzing results after IOLs implantation. So I'd like to focus this presentation on the differences that presbyopia correcting IOLs may show at aberrometry. Here are my financial disclosures. You see that I'm consulting for several IOL companies as well as for CSO. I don't want to go into details as regards how the Osiris Aberrometer works, because I feel that it will take too much longer. Just want to point out that this aberrometer has a huge spatial resolution that is not matched by any other aberrometers. At the same time, the sensitivity that the aberrometer has is so high as to be able to pick really subtle and little changes in the wavefront. And as far as I know, no other aberrometers are able to make the same. I'm presenting you to start with an aberrometry of a monofocal non-toric IOL set at -2 as the final target. So to better explain you how this aberrometry readings should be interpreted, here is let's say the part regarding the wavefront error in terms of microns, and here is the total wavefront error. You see here the wavefront error, again in microns for low order aberrations in this part of the image, and here the high order aberrations wavefront error in microns. This is pretty much what the aberrometers do, generally speaking. One of the biggest advantages, though, of the Osiris is to provide a power map of the aberrations. So not the influence on the aberrations in terms of the heights and visual problems. This is more related to how the light is distributed through these aberrations in terms of dioptric power. And reminder, this is a -2 non-toric IOL, so the map entirely reads slightly red. I don't know if you can read here. Red means myopic. And here you see that dioptric power map of lower aberrations. In this case, is totally red because, as I said, the myopic outcome is there. And here is how the high order aberration map looks. So here there is a little bit of a background rumor, as you can see, but the map generally looks like green, meaning plano. So in this case, we have an IOL that is myopic as an outcome, but with almost no high order aberrations. Let's see how sensitive this device is in another map of another eye that ended up being slightly myopic. And again, I'd like to focus your attention on that part of the image. Because here as well, if you can look at the map, you will see this reddish outcome. You'll see certainly on the lower aberration map, the presence of a little bit of astigmatism, not so much, well, a couple of diopters as you see here. But what is most interesting to really assess the resolution is all of that. What do you guess is this? This perimeter actually is the perimeter of posterior capsulotomy that has been done in the past. And look at also here, you see some striae. These obviously are not striae, these are strands in the vitreous body. So the accuracy, the sensitivity, or the spatial resolution of this aberrometer helps you and let you really capture very subtle changes in the way that the light is projected to the eye to reach the macula. So let's start then from a monofocal IOL to see how presbyopia correcting IOLs look like. Again, here is a spherical plano. Don't forget that the background noises that I was telling you earlier, so a little bit of, red, yellow spots, but averagely speaking, the lens looks green, meaning no dioptric power as regards high order aberrations. Here is an image of an extended depth of focus non-diffractive IOL. And again, you see that overall, we can say that the lens delivers some greenish color, but with extension to red and blue, meaning the extended depth of focus that the lens is able to translate into the eye. And here you see a hybrid EDOF diffractive IOL, where you see the central part being more likely to this part of the EDOF, while the periphery of this lens look more like a traditional diffractive IOL. Let me go through examples to let you understand how this kind of technology may be useful to address some specific cases. And again, I'm starting from a case of an advanced monofocal IOL, the ions from Johnson & Johnson. You see here that compared to what we saw earlier, we see a little central red bump, meaning the lens delivers light in the myopic range. And this is what the ions lens is supposed to be, like a lens delivering most of the light for distance, but with a little bit of a central part that delivers for intermediate. Here is a traditional diffractive bifocal IOL, the Restore 3.0, and here you can probably see the kind of sinusoidal aspect that this lens has in terms of power dispersion. Here is a traditional diffractive IOL. So what changes from the previous image, again, you see the sequence of the steps that is not 1-to-1, now it's 2-to-1, so given the third focal point. And in this case, there's another trifocal made from a quadrifocal project. Again, I think you can see and you can really make a distinction in between the previous image and this one, where here you can see the fourth focal distance that has been redirected to far. So green, in this case, plano. So the continuous wave is not 1-to-1, is not 2-to-1. In this case, is a wave, another wave, and then a flat area, a wave, another wave, and a flat area, as it is typical from the panoptics pattern. Here is an extended depth of focus diffractive echelet IOL. And what do we see here? We see not just colors going to red to improve intermediate. What we see here is colors going from hyperopic to myopic. So what's that? That's the most important, that's the most interesting part of this kind of analysis, I guess. So if you just look at the total amount of low order aberrations here in this area, you see again the lens looking pretty great. If you look at the measured aberrometry value in terms of refraction, you see the lens is set slightly myopic, or in this case, slightly hyperopic, so it's right there as a power. But the continuous change in the length of the focal point gives the final outcome. Each single step actually spreads the light from, let's say, elongating it from hyperopic to myopic as to demonstrate the elongation of the focal point. Here is another example, the trifocal diffractive EDOF IOL. That's the Atilara that you're probably familiar with. In this case, you know that the Atilara has been built to have basically the intermediate and near being so close as to give the patients or the eye the extended depth of focus property. And again, if we look at the low order aberration figure of this eye, we see mostly it being green. There is a little bit of astigmatism as well. In this case, we are in the range of half of diopters of astigmatism, so a very low value. But this total, let's say, amount of light dispersion bringing plano is given by a huge dispersion of light going in this elongation as we were discussing earlier. Let's see the next example. This is the Synergy from Johnson & Johnson. You may know that the Synergy is a lens that combines traditional diffractive technology, meaning the same technology of the Technis multifocal or the Restore, so the bifocal technology, on the top of which the EDOF component has been added as to elongate the focal point. But in this case, with the Synergy, the elongation is has not been set in between distance and intermediate as for the Symphony, but more for the distance in between intermediate and near. And I think that this image really represents pretty well what the Synergy does. So the central part brings that very extended depth of focal ability. So again, colors are ranging in between red to blue as to demonstrate the extension. The outer part of the lens actually looks more like a traditional diffractive one, without that bluish area and reddish area that is more in the center. So this lens really looks like, and here is a rate illumination image of the same eye, it looks like the extended depth of focus portion is more like in the center of the lens, while the periphery of the lens that you see here is more for focusing at near only and intermediate and distance only. And what is again very interesting to see is that these very complex optics when analyzed, when evaluated only for assessing low-order aberrations, well, it looks like plano. So all these complex colors finally just bring the lens being plano that as it was intended to be. Here is another design. This is a refractive spherical aberration designed EDOF, so the mini-well from CIFI. You see here how the central part is, let's say, set as to be slightly transferring the light to the myopic side, so giving more on the minus side, while the mid-periphery is more on the opposite side, so giving a little bit of hyperopia. So again, why is it so interesting? Because the combination of these two different patterns actually, again, give the plano value with a little bit of astigmatism again. Here is 0.75 diopters, but the lens itself as the entire optical plate actually delivers light both at distance, at the intermediate, at near, at the same time. So again, with this kind of technology, you can really see where is your power in terms of distribution into the eye. And here is again another one, and this is a refractive but Axicon design EDOF IOL. That's from the company called SAV IOLs from Switzerland, and the lens commercially is called Lucidis. You can see here again a red central spot. This red central spot transfers light for intermediate and near, while the surrounding part is more for distance, in this case being only on the green side. So the combination again, and here there is a little bit more of astigmatism, the combination of the entire optical plate gives an average that is slightly myopic in this case, but again, I find it very fascinating to see how this combination of powers at the end of the day are going to deliver the light only on one focal point. If you're plano, this complex optics again delivers light as low order aberrations to plano only. Let's move on and see one of the most recent EDOF IOLs that have been launched in the market, the Alcon Vivity. Again, you see here the optics being all in this case even more complex. So in this case, what we do see is a lens that it is able to again focus at plano, but through different areas. Alcon says they are wavefront shaped to distribute powers from positive to negative to extend the focal range, the focal depth of the IOL itself. And again, you see in this case how the retroillumination shows almost nothing. This is why this lens is so difficult to see at the slit lamp, but optically speaking, it does the job that it is supposed to do. So the aberrometry that we see in different IOLs is so amazingly variable, so amazingly different, but this may help you quite a lot in understanding why some of them, and here for instance I'm referring only to EDOF IOLs, why some of these lenses are inducing more halos and glare than others. Because if we start from this lens that is a spherical lens set to plano, and as I said, this is just background noise, and we compare this dioptric power measurement to that of a diffractive IOL like here, well, it's kind of obvious to understand how these patterns deliver more halos and night vision problems than a monofocal lens. But at the same time, if you may want to compare, for instance, what a refractive shaped EDOF IOL transmits the light compared to traditional diffractive patterns, again, you may really not only being told by the patients, but you can really appreciate from, like say, a diagnostic point of view, while this lens is definitely closer to a monofocal than to a diffractive in terms of halos and night vision problems. But then there are some additional uses, some additional applications of this technology that it's worth mentioning, because they may help you really solving some specific cases. Here is, for instance, a lens that, if you look like just here, looks like quite the center. The point is that what we are analyzing is what is in the center of the pupil. Here is the pupil. If you really want to see if the lens is the center, you have to compare the central disc to where the first Purkinje image is. And here is exactly the situation. So this lens looks like the center, but due to the kind of larger kappa angle that this eye has, actually the lens looks like centered. And this is another example of the same situation. The lens looks like the center in this direction, but again, if you compare where the center of the kappa angle is, so the first Purkinje image, you see that the decentration does not look as wide as it is if you just compare to the center of the pupil. And then you can really evaluate other features like real decentrations. And I think it's important to measure and to assess these decentrations, especially in all these refractive IOL patterns, the presbyopia correcting refractive IOL patterns. Because when you see them at the slit lab, you will not see anything. So if you will not see anything, and the patient for any reasons is complaining, you will not understand if the patient is complaining just because of the lens or because of the lens being decentered. So here is an example where you can see very well lucidity that it is decentered, inducing some coma, as you see here. Here is another case with a diffractive IOL that has been decentered to the capsular constriction. You see here all the capsular striae that determine the decentration. And here you see a mini well, so a spherical aberration refractive id of IOL that is superiorly decentered. And you see here the huge amount of coma that this decentration generates. So this information would not be able to be captured unless then with this kind of aberrometry. Here is another case of decentration, where you can see here also the phimosis of the capsule, and that was probably the reason for the decentration. But you can use this device also for other purposes, like really evaluating, for instance, the accuracy of your axis alignment with toric IOLs, in this case, presbyopia correcting toric IOL, because you can use the MS39, so the anterior segment of CT, as the screening tool for having the cornea evaluation of the eye. And you can use the Osiris to evaluate the internal, the ocular aberrations as a whole. And through subtraction maps, you can really have what is the inner aberrations only. So this is the aberration of the lens. And what we see in the lens is obviously the diffractive pattern plus the presence of the astigmatism. The lens brings the astigmatism in the same axis the cornea brings the astigmatism, which means that the lens is pretty well aligned. Here is another example where you can see where it is interesting to discriminate where the internal aberrations or any aberrations are coming from the cornea or from the inner part of the eye. Here you can see some coma when evaluated on the whole aberration map. Here you see the aberration coming from the cornea only. So again, the coma we are talking about. And you see here that internal aberrations as subtracted from the corneal aberrations actually are showing the pattern of a presbyopia correcting multifocal diffractive IOL, but with no coma at all. So the responsibility for this coma as the whole system, the whole measurement was not coming from inside, but only from the cornea. So just to conclude, I think that the aberrometry made through the Osiris actually gives very valuable information, because not only it's a good way for precisely refract these patients, sometimes conventional aberrometers are not able to refract them, but through this analysis you can really assess what type of IOL has been implanted. You can really assess the properties of the IOL. You can really discriminate in between centration and pseudocentration, and if you already have the MS39, so the anterior segment OCT, you can get all the information related only to the internal aberrations that will not be able to be measured in other ways. So I thank you very much for your attendance, and I am supposed to see if there are questions. If you don't mind, I just, in the purpose not to run too late, I can answer these questions directly on typing on them. I don't want to take too much of your time. It's already 6 o'clock. So, Farhad, do you agree with it? I'm very grateful about you and the other speakers and all the audience spending this Friday afternoon with us. I'm so grateful also to CSO to having given us this space, this area for presenting our data, presenting our research. And again, if you want to say something, just to say bye-bye to all the group and thanking them, you are very, very welcome.
Well, from my side also, thank you very much for moderating in an amazing way as always, Francesco. And let's all stay in good spirits. And thank you again, CSO, for giving us the platform. And enjoy your weekend.
Thank you. And again, now you will see a little clip from Veronica Mura, the CEO of CSO, to thank you. And hope to see all of you soon, not only virtually, but by face. Thanks.
At the end of this first experience, CSO wants to thank you very much for a large number of people that meet today. We remind you that the exhibit section will remain open in the coming days. We'll keep you informed on next events. Thank you again to everybody.